I'm Laura. I work at JDRF on the insulin pump program with Melanie, and I'm just here to give a bit of lived experience, I guess, to the chat today. So yeah, I'm 33, diagnosed with type 1 when I was 10. So I've been living with a condition now for about 23 years. I have a 2-year-old, beautiful little toddler called Ivy, who's also a handful. And I'm also 33 weeks pregnant with my second. So in terms of my pregnancy journey, I guess like a lot of mums with type 1, it starts a bit earlier than usual in that there's a lot of pre-planning. So I had to chat with my diabetes team about sort of diabetes management, getting that in order before falling pregnant. And then, and they were very, very supportive in, my decisions to want to fall pregnant. So I just worked with them in getting things in line, making little changes to the way that I manage my condition, things such as, pre-bolusing, getting that down pat. And they made, the small changes that I made big difference in terms of my HbA1c once I fell pregnant. So in terms of being pregnant, both my pregnancies have been very similar in that I experienced initial blood sugar level spikes in my first trimester. And once those were under control, it was smooth sailing until around 30 weeks pregnant. And that's when I've started to sort of experience the insulin resistance that I think is quite common for women with type 1 diabetes to experience. And that the way to manage that from what I found useful was that I'm constantly in contact with my diabetes team. So I'm very lucky in that I'm able to contact them weekly and they help me manage my doses and my rates. But also things like, for example, walking helps. So I have done a lot of walking when my blood sugar levels have been high. The other night I was walking up and down my stairs at midnight the other night because my blood sugar levels were high and there was no corrections were helping bring it down. So I just was walking up and down my stairs. I also, to help manage the resistance, I, where possible, try to eat low carb, but with pregnancy cravings, it's not always possible. So for example, I know that when I wake up in the morning, I experience, once I eat breakfast, I experience like that I'll shoot up quite high and stay high for the rest of the day. So I just try to manage that by eating lower carb breakfasts and then going for a walk and trying to get the insulin resistance and the insulin to kick in.
Sorry, I was going to ask you a question, Laura. Can I ask about when you were thinking about being pregnant, so when you're thinking about falling pregnant, sort of what's the extra stuff? I know as someone who doesn't have type 1, I have a son that has type 1, but as someone who doesn't have type 1 thinking about falling pregnant, I think there's lots of sort of anxieties and worries and stress that come with that. What sort of extra stuff, what sort of extra bits did you find, I guess? Because I think I hear a lot of people, struggle with that and worry, and there's that sort of, I think you've even said to me before that, when you were diagnosed, they said you worry about not even being able to have babies, and a long time ago they would, I think, give that sort of advice to people, is that it might be difficult and things like that. So yeah, I guess where were you with that?
There is a lot of worries. I think in my experience there tended to be a lot of being told what could possibly go wrong. So, having high blood sugar levels and how that can impact the baby and the birth, and being able to breastfeed and whether someone with type 1 can breastfeed or not. There was, like a lot of those sort of concerns. And
so was it from negative, like comments that you were getting from other people that was sort of? To be honest, all around. I mean, my diabetes team was very supportive in that they were very realistic in the advice that they gave me, particularly my endocrinologist. I've heard from other type 1 mums that their teams cannot be as supportive, and they try to push them to get their HbA1c down to a really, difficult to manage, difficult to reach level before falling pregnant. But my endocrinologist was quite supportive in that. He was happy with
how things were going. And yeah, did that answer your question, Mel? Sorry.
Yeah. Jane, I don't know, Jane, have you found that? Yeah.
Okay, so as we're talking about pre-pregnancy, let's just cover off on a couple of things there. Okay, so ideally a pregnancy is planned so we can make sure that all the I's are dotted and the T's are crossed. So firstly, it's ideal to try and aim for an HbA1c of less than 6.5. But as Laura's just said, sometimes that's easier said than done, and we need to be pragmatic. And generally, if the A1C is less than 7% or near 2, most teams will say that that's a safe place to fall pregnant. Now, the reason why we aim for that level of tight glucose control is that 8 weeks after your last period, when you're 8 weeks pregnant, your baby has got all its bits and pieces. Your little baby has got a little pancreas, a little heart, eyes, whatever. And then the rest of the pregnancy is about those things maturing. So ideally, you want those bits of the body forming in a near normal environment. Now, every woman, whether they've got diabetes or not, there is a risk of things like congenital abnormalities. So these are things like cleft palate, something that can be easily fixed to something that might be quite major. And the risk of these sort of complications is about 0.6% in all pregnancies. If your A1C is 7%, it's around 1%. If your A1C is 9%, it's about 10 to 16% risk of these problems from occurring. So the take home from that is, if you can get your A1C down less than 7%, then you're trying to get the best possible outcome. But if you happen to have, you're using contraception and then, you get gastro and then, that contraception doesn't work and then suddenly you find you're pregnant and your glycemic control is not perfect, don't beat yourself up, okay? Because there's still a very good chance that everything's going to go okay. So ideally we get the HbA1c down to reduce your risk of those sort of issues happening. There are other things that we need to check. So for example, we need to check your thyroid because often women with type 1 diabetes will also have what we call subclinical, so you're not getting any symptoms, thyroid irregularities. And while that's okay when you're not pregnant, when you are pregnant, if your thyroid's not spot on, there's an increased risk of miscarriage. So we want to get that right. Ideally, you're on some pre-pregnancy vitamins. And, if you don't have diabetes, as an example, we would also get you to take folic acid. We'd get you to take a tiny dose of folic acid. But when you've got type 1 diabetes, we like to have an increased dose, 5 milligrams. It reduces problems further down the track. So ideally, you plan your pregnancy, you work with your diabetes team, you have all the checks done just to make sure everything's okay. That includes checking whether you've got any changes in the back of your eyes or your kidneys. Doesn't mean you can't have a baby if you do have some changes in the back of your eyes. We want to keep a close eye on the before pregnancy and during pregnancy. So we want to know what it is that we need to, as a healthcare professional, look after to make sure you and your baby are safe during that pregnancy. Does that make sense?
Yeah, I think that's great advice. I think there are those ones where, those surprise pregnancies and those ones that I think, and I know, Laura, we've spoken about it before, is that the extra anxiety and worry that causes people just is huge.
Yeah, look, I do get that. I do get that. So I remember a very wise woman told me when I was pregnant with my daughter that the lump in my stomach would go, but the lump in my throat never would. Mm-hmm. And that lump in your throat really starts in the pre-pregnancy stage, doesn't it? Am I going to fall pregnant? Are there going to be issues with that? And, generally women with type 1 diabetes, they have the same amount of infertility problems as the general population. So having type 1 diabetes per se does not necessarily mean that you're going to have more trouble falling pregnant than your friend that doesn't have diabetes. It's just that we're going to keep a much closer eye on you leading into the pregnancy and during the pregnancy to make sure you have the very best outcome.
And that can only be a good thing, I think, when you're pregnant.
Yeah, absolutely.
I think that can be really assuring, like reassuring during your pregnancies. I think sometimes, you know, I had friends who've been pregnant and they don't, you know, there's no risks, there's no dramas, and it sort of can sometimes feel alone. So sometimes there's a niceness of having this extra support.
Yeah, look, every pregnancy, there are risks with every pregnancy, you know, so our first pregnancies, women are much more likely to have issues with their blood pressure, okay? So there are strategies that we use in women with type 1 diabetes. Laura, were you put on a low-dose aspirin when you were pregnant?
I was, yes. So I was put on a low-dose aspirin when I was pregnant with Ivy, my first born, and I did go on to develop preeclampsia at week 36. This time round with my second pregnancy, I was put on the low-dose aspirin earlier. So I was put on straight away once we found out I was pregnant to try and prevent it, to prevent
That's right. So there are strategies that we can do. So having type 1 diabetes, like first pregnancy is an increased risk in itself. First pregnancy and diabetes are slightly higher risk, but there are so many things that we can do, such as we now know that low-dose aspirin really reduces your risk. So, you know, don't ever think that having diabetes means you can't have a pregnancy. You certainly can. You've just got to put a little bit more thought into it.
I think it's like everything with diabetes, isn't it? I always feel like there's anything, you can do anything with diabetes in your world, but there's just some extra steps that sometimes we need to do to get there, you know, like.
Yeah, look, it would be nice if it was all set and forget, but it isn't. Now, one of the things that Laura alluded to was this increased insulin requirements during pregnancy. And that's also not unique to someone with type 1 diabetes. So all women, by the time they get to their third trimester of their pregnancy, need about 3 times the amount of insulin to control their blood glucose levels as they did prior to pregnancy. It's just that if you don't have diabetes, your pancreas just, you know, rises to the occasion. And when you do have diabetes, well, the insulin you're getting is the insulin you're taking. And therefore, you are going to see that dose increasing and having that weekly contact with your team and having that adjusted. And a lot of that increase in insulin there's a bit of an increase in the background insulin requirements, but a lot of it's around food. And Laura talked about trying to have a low carb diet, and we can certainly have a lower carb diet, but you've got to be a little bit careful about having a low carb diet because baby needs a certain amount of glucose. But, you know, we can do things like, and Laura, you mentioned something that we often say, a lot of women complain about their glucose spiking at breakfast, even when they're not pregnant, and that is magnified when you are. So there are strategies such as, you know, giving your mealtime insulin half an hour before breakfast rather than the standard 15 minutes. Strategies such as, well, let's have a lower carb breakfast, say, you know, 20 to 30 grams at breakfast, and then a couple of hours later have another snack that's a reasonable size. So sometimes we can, and this is obviously what you did, Laura, you just sort of manipulated how much carb you're having at breakfast, so it wasn't quite as big as what you had at dinner, as an example.
That's right. Yeah, that's right. Yeah. So I was still eating carbs for breakfast. I'm just not.
Oh no, I didn't think you were, but I'm just, you know, some people think that they're going to manage it by having a low carb diet, and you certainly don't have to have a huge amount of carbohydrate. You know, you don't have to eat twice what you've been eating before, but you do need to have some.
Yeah. So I thought I might jump onto sort of the labour that I went through with Ivy. So as I mentioned, around week 36, I developed preeclampsia, and I was diagnosed with it on the Friday, and then they decided to induce me the following day on the Saturday. And in hindsight, I look back and I was very underprepared. I knew that I wanted to manage my own diabetes during the labour. I didn't in the sense that I wanted to sort of, keep control of, I'm using a pump and a CGM. So I wanted to just keep control over that and not go onto any sort of glucose drip or infusion, which I'd heard of before. However, I was underprepared in the sense that I hadn't changed my set or my CGM, and my CGM was actually due to run out that same day. So I was induced, and then I changed my sensor over after I was induced. And I think just with the stress of the induction and probably the hormones and everything, and then having a sensor that has just been inserted, it's first day, sometimes they're not as accurate as they can be on that first day. Things just went a bit chaotic in terms of my blood sugar levels. And I also, in hindsight, should have probably taught my birthing partner, my husband, how to help manage my diabetes during labor as well, because it was a lot. It was a lot to sort of go through all the pain, the stress, and on top of it, looking after that. So if in hindsight, I would have taught him to help manage and make the decisions for me in terms of the diabetes management. So after about 6 hours, a decision was made to, the labor wasn't going so well. So decision was made to have an emergency C-section. And at the time, I remember being quite concerned. I remember looking at my blood sugar levels were maybe around 12 or 13. And I was really concerned that I would go low during the C-section. So I made the decision. I was like, I'm not going to correct. I'm just going to stay high.
So you kept your pump on, but they were going to let you keep your pump on? That was...
Yeah, that's right. So I kept my pump on, kept the sensor on as well. During the actual, the surgery, I was just in complete control of everything. So the birthing team didn't really check my levels or anything at all. They just let me manage it all. So I had my pump with me. I didn't have a hypo kit with me, which is also probably something I should have thought about. And yeah, I was able to just sort of have my pump next to me, and if it buzzed, I was able to see what was going on and manage it that way. In terms of, so I was quite high when Ivy was born. My blood sugar levels were quite high. I think once she came out, I was sitting at around 16, and I later learnt that I think that can have quite a big impact on babies' blood sugar levels once they come out. And she ended up in special care for a few days with low blood sugar levels. She needed to go onto a glucose drip. It could have been, I guess, because I was high. I don't know. I don't want to put two and two together, but it can, I think, affect it. Is that right, Jane?
Yeah. So can I just pick up on a couple of points?
Yeah.
Really good points that you said. Labour's not much fun, guys. And even though you might be in total control of your diabetes at any other time, it's always good to have a backup person. So if you're on an insulin pump, for example, it's good that your partner knows how to do a set change for you. It's good that they know how to put a CGM on. It's good that they know which buttons to push if they need to give you a bolus, for example. So that's number one. Make sure they've got those skills. Number two is ideally we try and keep your glucose levels tightly controlled during labour. So there is a chance that your baby will go to special care nursery regardless, because they just want to keep a close eye on baby, and better that happens and baby has low blood glucose levels without someone picking it up. So most units for a woman that's got type 1 diabetes, baby will routinely go to special care nursery. It doesn't mean there's anything wrong. They just want to keep a close eye on.
Okay.
But as Laura said, if your glucose levels are high during the labour, so baby is getting glucose from you while he or she is connected to the placenta. So if your glucose level is high while you're in delivery, baby is being given extra glucose, and that's going to stimulate the baby's pancreas to work harder. And then as soon as the umbilical cord is cut, baby now needs to eat to get glucose. And a baby that's got high glucose levels will be a sleepy baby and less likely to be able to suck hard enough to get the colostrum. So ideally, we try and keep the glucose levels as tightly controlled as we possibly can during delivery, just to sort of minimise the sort of low glucose that can occur in the first 24 to 48 hours. Now, Laura, you were induced at 36 weeks because of your high blood pressure. Most obstetricians and diabetes teams won't let you go past 38 weeks. And they like to plan the delivery. Now, the reason for that is a normal gestation is between 38 and 42 weeks. And after 38 weeks, the placenta can start deteriorating. And that's more likely to happen if you've got an autoimmune condition. So they want to get baby out before there's any chance of your placenta deteriorating. The other thing is that what puts us into spontaneous labour is a sudden drop in our estrogen and progesterone. So the reason why you become insulin resistant, particularly in that third trimester, is baby's now big enough to be stabbing your uterus left, right, and centre. And when you poke a muscle, the response of that muscle is usually to contract. So during that stage of pregnancy, we've got really high estrogen and progesterone levels and some other hormones to keep that uterus, that muscle relaxed and allow it to keep growing. So what puts us into spontaneous labour is when that estrogen and progesterone level drops. So that also impacts how much insulin you need. So if we let you go into natural labour, there's a chance that you're going to be hypo. So that drop in your insulin requirements can happen anywhere within going into spontaneous labour and a couple of days after. Did you find that, Laura, your insulin requirements dropped after you had your little one?
Yes, quite drastically actually. And there was a lot of lows to deal with. And I feel like that went on for quite some time, maybe a week or so.
Yeah.
And then the combination of breastfeeding, it was, a lot.
So you can actually, especially when you're breastfeeding, that's a very energy hungry time. So by the time you get to your third trimester, you need 3 times the amount of insulin that you require before you're pregnant. And then often in the week or so after, you need even less insulin than before you were pregnant, because the estrogen and progesterone have dropped. You're now producing breast milk. That takes energy. You become more insulin sensitive and so on. So we would normally write a delivery plan talking about what to do with the insulin if the glucose is such and such, and what to do with giving you something to drink or an IV glucose infusion if it's low, to try and keep those sugars nice and smooth. And then once baby's out, what to do with the insulin you're taking with food, or what changes should be made to your insulin pump so that you're not having these hypos.
So Jane, is that delivery plan written with your educator? So people would go and see their
it's usually done with your obstetrician. I've written some delivery plans myself because I work quite closely with the endocrine team and obstetrician to do that.
Well, most obstetricians across the diabetes stuff, like it, because I know generally we find it not everybody has a really great understanding of type 1. Not all our medical professionals, unfortunately, in hospitals have that great understanding. So I don't know what people's experiences are. Are they finding that the obstetricians they understand enough, or is it?
Okay, so it's done in collaboration with the obstetrician and the endocrinologist, or the obstetrician and the nurse practitioner. Okay, so it really is a team approach when you're pregnant and you've got type 1 diabetes, and there may be some other specialists involved as well. So you might be seeing your ophthalmologist a little bit more regularly. Did you have your eyes checked each trimester, Laura?
Yeah, I did. Yeah. I had extra checks on my eyes.
Yeah. So there's a lot of growth hormone when you're pregnant, and that means if there's any changes in the back of your eye, they can just speed up a little bit in pregnancy. 5 years down the track, it makes no difference. It's just that when things happen, it speeds up during pregnancy, then it slows down in the next year. So you just want to be having your eyes checked, and if anything, looks like you might need, a little zap of laser just to stop anything becoming a problem, a stitch in time saves 9, that sort of thing. So it really is a team, with you, Laura, being the most important person in that team, but with all these support people around you, such as a dietitian, nurse practitioner or diabetes educator, your obstetrician, and your endocrinologist. And Mel's right, okay? 95% of people with diabetes have got type 2 diabetes. And even when you work in diabetes, that may be the bulk of your experience. So ideally, when you've got type 1 diabetes, you want to go and see someone who sees more than 5% of the people have got type 1 diabetes, especially when you are pregnant. So in some situations, you've got a really great endocrinologist that you feel very happy with, but they might want another endocrinologist to look after you during the pregnancy who has far more experience in it. So you might stay with your same team, but on occasion, your team might suggest to you, we don't do enough pregnancies to feel comfortable managing you. We suggest you go and see this team. And then once you've had the baby, you go back to your original team because you like them and you get on well with them and you've got a great system going. But on occasion, you might need to see someone else.
Did you find that, Laura? Because I remember there was someone that said something. There was some strange information or something. I can't remember what the comment was now when you were pregnant.
So my experience was I saw my private team, my private endocrinologist and diabetes educator, who managed the diabetes side of things throughout the process, and they gave me a plan of post-birth, like immediately once Ivy was born, what I should do with my my pump settings. And they were supportive if I was interested in seeing the team at the hospital. So I went through the public system, and I saw a high-risk team at the hospital that I was birthing at, and they did have an endocrine team there that they usually preferred women that were giving birth there to go and see, just to touch base, and they would be the ones at the hospital that would have looked after me. But I was persistent in that I wanted to see the team that I was comfortable with, and it worked well for me. But I'm sure if I'd chosen the other option as well, seeing the public team, it would have also worked. So yeah, I sort of had both options. That makes sense.
It's good. I think that's what we want, isn't it? As many options. We've got a question.
Oh, before that, sorry, I just want to
yes.
in. Rose sent me a comment, which is very true, and it's true for all pregnant women, I think. She said, nurse, midwife, and person with diabetes here think we should remind people that we have autonomy and healthcare rights. Even if we have diabetes, we can make shared decisions with our care providers, and we don't just have to let the system make decisions for us.
Yeah.
Which is always so important.
Very important.
Sorry.
Yeah,
I just wanted to read that out. Yes, and then we do have the question.
Yes, we've got a question from, I've put my glasses on, I still can't see it properly.
Kritika?
How do we find obstetricians that know about type 1 diabetes? How do you search that? Often it's hard to find type 1 specific medical support anyway, but how do we find ones like that?
Okay, generally you talk to your diabetes team. Okay, so if I don't know of an obstetrician in a particular area, because I work across a fair bit of New South Wales, if I don't know of an obstetrician who has got experience in type 1 diabetes, I'll speak to one of the endocrinologists in that area and find out who is. So not everybody with type 1 diabetes sees an endocrinologist regularly. I'm not endorsing that, but that's the case. So it may be your GP that's helping guide you. So most major teaching hospitals will have a high-risk pregnancy clinic for people with type 1 diabetes, and working in there will be obstetricians who have experience in type 1 diabetes as well as the diabetes team. So the GPs can get on the phone, if you want to go private, can get on the phone and phone around to the various endocrinologists that they know work with people with type 1 diabetes. And that endocrinologist is probably going to be able to put forward a couple of names of obstetricians who have done a lot of work, with women with type 1 diabetes.
I think just back to that comment before about finding a team that works for you, I think it's important in everything that we do, and we need to, if you're not comfortable, then we need to keep looking. I think it's fun, any health professional that we see, then we need to.
I could not agree with you more. And I'll always say to people, I'm actually quite good at what I do, but I'm not going to be right for everybody. And when you've got type 1 diabetes, you do need to feel that you can go into the room and you're listened to. And that, because as I said to Laura, you're the center of the team. We're here to support you. We're not here to take over your care. We're here to advise and support. And if the person you see doesn't make you feel like that, even when someone tells you bad news, you should walk out feeling better for that appointment. So if you walk into the appointment and every time you walk out you feel miserable, you're not seeing the right healthcare professional.
And if you don't feel comfortable to say, I'm a psychologist by trade, and I used to have that same conversation, about people feeling comfortable at the end to say that they want to find someone else, because you need to feel comfortable with who you're speaking to say what you need to say and ask those questions. And it's often personality and all sorts of different reasons. So, I think it's always one of those most important things if anybody can do, and we can try. And it's not always easy to do. Like it's quite tricky to do sometimes. It's not always easy because you need to feel brave sometimes to do that. But it's well and truly worth it.
And it's a good time to start advocating. You've really got to advocate for your child once you're a mom. So get into the practice of speaking up.
Yeah.
And
I think, with type 1 comes a lot of advocacy and a lot of pushing, but parents all together anyway. I think I was just thinking back, I just had a comment. So my son Will, who has now type 1, went to special care with low blood sugars after he was born as well. And I didn't have diabetes.
So that's actually interesting.
So it's quite common, isn't it?
Yeah. So we think that, children of people with diabetes have lower blood glucose levels than people, babies of women who don't have diabetes. But it's truth be known, we don't actually check the glucose level of every baby. So it could be a bit of a normal phenomenon that just happens to be seen more often when you've got type 1 diabetes. But certainly we do know, if you look at what the mum's glucose level has been leading into delivery, there is certainly a relationship between.
Makes sense, doesn't it?
Yeah, because that little baby is making its own insulin, and you know what it's like. I don't have diabetes, but I've been on a couple of diets in my life, and when you're eating low carb, you get up the next morning, you're not hungry, but you're doing really well on the diet, and then you think, well, I'm going out to dinner tonight, I'm going to eat whatever I goddamn like, and the next morning you wake up and you're starving. And that's because when you've had that big meal, you've stimulated your pancreas to work harder, and you've got this extra insulin in your system, and it takes your pancreas a while to back off on that. So that's what's happening with the baby. It's been out and partying when your glucose level has been high, and it's just going to take a little while for the pancreas to sort of recover from that and realise it doesn't need to make so much insulin.
Just on that, Jane, so we've got a question from Brooke saying, with babies ending up in special care, so why does the baby's hypoglycemia need to be treated with IV glucose? Can they not sort of do the colostrum or oral, anything else like that?
Yeah, no, they sometimes do. Okay. So they keep an eye on the glucose, and sometimes they'll give baby a feed. But if it drops too low, they will give some IV glucose.
I think with my experience as well, because I was induced early, so 36 weeks, and I believe expressing colostrum beforehand, they don't recommend until 36 weeks or beyond. So unfortunately, I didn't get to express any for IV, and they attempted with the gel to bring her blood sugar levels up, where they put the gel around her mouth. I think it's a sugar gel, and that didn't work, unfortunately. So then she went on the IV, the drip.
So they try not to put cannulas or drips up on babies if they can prevent it, but you also want them being safe. So most special care nurseries will only act if they need to act. They don't do these things unnecessarily.
We did get a question. Oh, sorry.
Yep.
No, I was going to butt in with a question, but you go for it, Mel.
This was a question that someone emailed in during the week. And they said, I'm sure you're not allowed to recommend specific pumps for pregnancy, but I'd love if there could be some talk about what you need to take into consideration when switching to a pump and thinking of family planning. I'm currently leaning towards the IPSO pump.
Okay, so number one, there are no pumps in Australia that are approved for use in pregnancy in the closed loop sort of system. Okay, so we can use pumps, but if you're looking at a system that is using the CGM data and then the pump is manipulating the background insulin or giving little corrections, none of the pumps have got the TGA approval to be used that way. That said, we do use them that way, but we do that, you know, giving you informed decision, you know, why we might use the closed loop feature of it versus using it as a traditional pump. Okay, so that said,
why is that, Jane? Why is it just because the research hasn't been done, or what?
Exactly, because the research hasn't been done. Now, when you're pregnant, okay, so outside pregnancy, a normal blood glucose is 3.9 to 10. Inside pregnancy, a normal blood glucose is 3.5 to 7.8.
Okay.
So by the time you get through your first trimester, you've actually got more blood on board. So when we're measuring glucose, we're measuring particles of glucose per litre of blood. Now, when you're pregnant, you've got more blood. So that is more dilute. Okay, so a glucose of 3.5 in pregnancy is probably about 4 outside pregnancy. Now, the closed loop system, so these are the ones that take the CGM data and manipulate the insulin. So if we look at the Control-IQ T-Slim pump, for example, it's going to be trying to keep your glucose between about 6.3 and 7. If we look at the Medtronic 780 pump, we can set that glucose target down to 5.5. If we look at the Ypsomed pump, we can set that glucose down to 4.4. And in fact, the Ypsomed pump does have approval for use in pregnancy in Europe. We just don't have that here yet. Now, the glucose that we want to aim for, Laura, you tell me what your team told you, but essentially we try and keep that fasting glucose as much as we can sitting around 5. So I've just said that the Medtronic pump at the lowest target is 5.5, okay? That the Control-IQ is just a little bit above that. So some endocrinologists feel uncomfortable allowing you to have that glucose sitting that little bit higher. And our aim is trying to get 70% of your glucose readings, and it's impossible to do 100%, 70% between 3.5 and 7.8. Now, I have used all 3 pumps in pregnancy in that closed loop system because what we've been doing by ourselves, manipulating the insulin, making changes to the settings, we haven't been able to achieve 70% time in range. And going to that closed feedback system with improved the time in range. So is that ideal? No, but we're getting better outcomes doing that.
Yeah.
So every team, there are some teams that are going to feel more comfortable using those systems in that sort of closed loop responding to the CGM. There are other teams that will not do that at all. So these are conversations you need to be having with your team. So if your team says to you, we're not going to let you use the closed loop, you can have CGM and you can have the pump, they're just not going to be responding with each other. It doesn't matter which pump you have. Yeah. And a pump is probably, we could use the Omnipod as an example during pregnancy. It tends to be better than using injections, because we can manipulate the background insulin more. So, for example, if you're finding that you're waking up high, if we increase your background insulin, your basal insulin, you're not just getting more background insulin at that time, you're getting more background insulin over the 24 hours. And there may be another period of the day where you don't need so much. So having an insulin pump, some form of insulin pump that is infusing rapid acting insulin every 5 minutes, if we can sort of go, well, at this time of the day, you need more background insulin and this time you need less, that can be set with an insulin pump.
Yeah.
So if you can get really good time in range with injections, fabulous. Not everybody has to have an insulin pump.
No.
But some people, the long-acting insulin does not work the same in every person. And there are about 43 different things that affect your glucose levels. And you've only got control over some.
Yep.
And how much those things affect your glucose level is different person to person. So you know how sometimes you see on Facebook and Instagram people who've got like 90% in target and they're using injections, and sometimes that makes you feel really bad because you can't do that. That person's diabetes is not the same as yours.
No.
So don't compare yourself. And the right treatment in terms of be it pump or injections, your obstetric team, your endocrine team, is not the same for everybody. It's got to be what's right for you.
Yeah. That's excellent advice. I think it's great.
Yeah.
Does anyone have any questions? I don't know, Laura. Laura, I know you've got.
Look, this is
Yes, go.
common question. I thought maybe I'd just bring it up because it hasn't been brought up yet, but maybe Jane, you could have a quick chat about, and this was a concern for me during my first pregnancy, especially the chances of having a baby that goes on to develop type 1.
That's a really good question, Laura, and it's good that you're a mum because it's 1 to 2% if the mum has got type 1 diabetes, and it's between about 4 and 8% if the dad's got type 1 diabetes. So really, your chances are pretty good that your children are not going to get type 1 diabetes. And if they do, it's not necessarily you, okay? So if your partner doesn't have type 1 diabetes, it doesn't mean he doesn't carry the gene that is associated with type 1 diabetes, because lots of people do, but only a small proportion of those people with that gene will be turned on and they'll go on to get type 1.
I think there was in the chat, Jane, as well.
Oh, what about if both partners have type 1?
Yeah, both partners.
Yeah, that is a higher risk. That is a higher risk, about 10 to 14% off the top of my head, if I remember correctly. But that's still really good odds. I
want to turn them around and say it's 99% not chance. And
that's what I was just about to say.
Sorry, Jane.
No, Mel. Well, yeah, we think the same. That's it.
Yeah.
Like, I had my last child when I was 40. So my risk of Jack having Down syndrome was higher than your risk, your children's risk of getting type 1 diabetes if both of you have got diabetes. So I think if you look at that sort of thing, you go, well, yeah, there's lots of 40-year-old women having babies. So there's no reason that, ideally you don't try and just date people that have got type 1 diabetes. But let's face it, you can't help who you fall in love with.
That's right.
That's right.
All these wonderful little community groups, you might find someone within there.
No, sometimes I think we need to do like type 1 speed dating.
Yeah. Oh, look, I've seen it on some of the groups. I've seen some Facebook groups that have those sorts of things.
Yeah.
On there. Why not? There's a level of understanding amongst people that have type 1 and have a connection that I don't think you can beat somewhere. Doesn't mean you can not have a great partner that doesn't have a connection, but
I know there's some questions there, but just I want to just quickly touch on breastfeeding. Okay.
Oh, yes.
So not every woman can breastfeed. And that's the same whether you got diabetes or not. Okay. So we used to have wet nurses in the good old days because there are certain women who just really struggle with breastfeeding. So if you can't breastfeed, do not beat yourself up. if you can breastfeed, well, that's fabulous, because these are with you all the time. It's much easier when you go out and about.
No
Okay?
sterilising. Yeah.
So when you do breastfeed, Laura, did you find that your glucose level would drop quite quickly when you were feeding?
Yes. And so I would keep a box of snacks with me that I would eat when I would breastfeed to try and keep my levels up. So I had like cookies, biscuits, juice, whatever. I had it all there, big pile of snacks next to me. Yeah.
So you need to be prepared. So don't sit down and then feel yourself going hypo and have to stand up and go and get something. So have popper juices all around the house. So if you sit down there to breastfeed, you've got a popper juice. It's always a good idea to sit where you're supported, just in case, you do have a hypo and you've got to search around, baby is supported. Just practical tips like that can make a difference.
Yeah.
Yeah, because I imagine it's lots of energy being used and expended, even without diabetes. I think breastfeeding's tiring. And but you've got all your emotional stuff that goes with it as well. And there's, your baby's upset, and you've got, I think that's one of the things I'm always in awe of, people that, that do this with extra stuff on board, because, just without that, there's extra stress and extra worry. And, we know that those 43 things impact all of that, and can impact your levels and all sorts of different ways of coping and the day-to-day stuff that comes with having a baby. So I think it's prepared is probably the best way. Set ourselves up for success is probably my motto, in terms of trying to plan and set things up. And I was thinking, when you were talking there, Jane, I was thinking, if I had a daughter that had type 1, I was thinking, all right, this would be my list. Like I can imagine myself, going to the doctor with a list of all these things and saying, these are the things that are important to try and find out. Because I think, I don't know about everybody else, but my brain forgets things when I go into doctors. So lists really help in that sense.
And especially when you're pregnant, your brain is just
completely, yeah.
Very true.
So any questions from anybody else? Feel free, you can turn your cameras on and ask the question, put your hand up, or like through the screen or whatever. But if you want to ask a question, or in the chat. What do we get any results from our poll, Mel? Who have we got in the room?
Sorry, let me find it. Yes, so most people, 41% were thinking about getting pregnant, and 32% were just here to learn for the future. So we didn't have very many actual pregnant people. 1 person in their first trimester, 3 in their second, and 5 in their third. So we've got 5 people who are heading towards the exciting time.
You said that 1 person's in their first trimester. So one thing that I forgot to mention when I said that, your baby's got all its little bits and pieces by 8 weeks, there is an increased risk of low glucose levels between about 6 and 9 weeks gestation. And that's because that's a very energy hungry time. So these days we've got continuous glucose monitoring, which is absolutely fabulous. Okay. So talk to your team about what you should set as your low glucose alarm in that first trimester. Okay, because glucose levels can drop really quickly. So you might want to set the alarm a little bit higher so that you've got time to take action to stop the glucose level from falling.
And I guess you have morning sickness and things like that to consider at that sort of time as well. And
well, that doesn't help, does it?
Yeah, I'm just imagining that on top.
Yeah, Laura, did you have some low sugars in that period?
Yeah, it's interesting you say that, Jane, because it triggered my memory with Ivy, when I do remember having a lot of lows, but I also remember the way that I distinguished them changed. So normally, I would have felt a certain way when I'm low pre-pregnancy, but during pregnancy, it was different. And I can't remember specifically how, but I do remember just thinking, like those signs that I'm low are different to what I would normally feel.
Did they go back to the same after, Laura?
Yeah.
That's really interesting.
So I think one of the reasons is that, sometimes your symptoms of hypoglycemia are driven by a change. Yeah. And so often when people are first diagnosed with diabetes and their glucose gets to 7, they feel hypo because they've been wandering around with these high levels. And then in that first trimester, you often got really tight glucose control. So a low glucose doesn't feel that different So the intensity of the signs and symptoms you might find are less. In the past, we would be really cautious around that time when people were just doing finger pricks, because first pregnancy, that's all you got to worry about. So you're probably doing lots of finger pricks and you're going to pick up your lows. Second pregnancy, you've got a toddler running around. You've got less time to worry about your diabetes. And on occasion, we did have some nasty lows around that time. But the lovely thing about continuous glucose monitoring, if you don't actually get the symptoms, it can warn you that you're going low. You do need to be careful with how much glucose you have, because I'm sure everybody's done this in the past. They've over-treated a low and then suddenly you've been high. So you've got to be a little bit careful about that. And even outside pregnancy, but especially inside pregnancy, if you do have a low, do not rely on your continuous glucose monitoring system to let you know whether you've had adequate treatment, okay? Because say you've drunk a small can of Coke. It takes 10 minutes for that Coke to move through your stomach and the glucose to get into your bloodstream. It then has to be pumped around your body and that glucose move into the interstitial space where you've got your sensor, and that can take another 10 minutes. And then it might take another 5 minutes for the sensor to do a reading. So you might look like you're still low on your CGM 15. Sure, that's a really good question. It's
like you were saying that there's no, the fertility rate is sort of similar across. It's not impacted.
Yeah, generally the fertility rate is you're not more likely to need IVF because you've got type 1 diabetes. That's not the case.
Yeah.
You probably don't want to wait to be 40 to have your first child when you've got type 1 diabetes, though, because it's not a given. But women with autoimmune disease, and that's not just type 1 diabetes, that's celiac disease, thyroid disease, rheumatoid arthritis, etc. There is a risk of premature menopause. So if you don't meet your partner until you're 38, well, yes, you're probably not going to have a baby till you're 39. Yeah. But would I necessarily suggest you leave it to you're 39 to think about a pregnancy? No, I wouldn't suggest you leave until you're 39. In terms of IVF, it's the same thing. We want to get the environment as close to normal as possible. So, you want to try and get your A1C as tightly controlled as you can. You want to be on folic acid. You want to be on a pre-pregnancy vitamin. On occasion, you might find with some of the drugs that they give you get little spikes in glucose, but it doesn't seem to be enough to cause any major issues.
That's good. And we've got a comment, and from Shanae, our lovely mum to be in the first trimester. Currently 10 weeks, have incredible insulin sensitivity in the last week or so. Short acting has been almost a third of what it would be taking typically. Also been less.
So there you go. There you go. That's exactly the sort of time that you think it's going to happen. In fact, I think you could give up on dating ultrasounds and just base dating on the hypos.
And so she's saying how good CGM is because she's been less hypo aware at that time as well. Yeah. Thank goodness we have CGMs.
Okay, now one trick, if you find your CGM's not, because Laura, you mentioned this, you said that your CGM tends not to be as accurate within that first 24 hours. So the tip is, so if you're meant to change your CGM on Tuesday morning, put a new sensor in on Monday morning. you're not using it, you're just popping it in and you're covering it with a Band-Aid, a big
Wet or
Band-Aid,
something,
so you
yes.
don't knock it. So one of the reasons it's less reliable in the first 24 hours is the little filament that's underneath the skin needs to be totally saturated to be able to give you accurate results. Now, one of the reasons there's that warm-up period is they think it's, as soon as it goes in, it's not wet. Let's leave it for an hour or two so it becomes wet. But if the truth be known, it gets wetter and wetter and wetter over the first 24 hours, and then you find it starts to be better. Yeah.
Yeah.
So that's a little trick.
Yeah.
Yeah.
Yeah, and I think that's a great. I have heard that before, actually. I've heard people doing that before, and putting it in earlier. You know, have you heard that, Laura? No.
To be honest, I thinking about it now, I've probably heard that before, but yeah, I wish I'd thought of that pre.
Well, now you know, it's a new
Yeah,
tip.
especially in that first trimester when you've got the risk of the lows. You really want those lows being picked up because, you know, Laura, you said you had them, and the lovely person who's online that's 10 weeks now said that, you know, she's needing about a third of the amount of rapid acting insulin. So, and she's not feeling them the same way. So if you've got the CGM, you want it being accurate, so it's giving you that pre-warning.
And then Caitlin has said, I don't feel like I experienced any sensitivity in the first trimester. I waited and waited, but had very few lows.
I think this is the thing, isn't it? About everybody different. Just like I think you can have, like, I always think the same person that has type 1 can have completely different days, 2 days in a row. And, you know, then there's all the variability across every single individual who has type 1. It's just, only there was a one size fits all.
That's right. So there is certainly some generalizability. Okay. Yeah. So a lot of women, you will be at high risk of lows in the first trimester. Will you have a low? You may not. I haven't seen anyone get to the end of their pregnancy without needing significantly more insulin than when they started.
So what else, Laura? So we've done, so it seems as though we've got lots of people that are planning pregnancy. So we've covered all those sorts of things. Now, one of the things we're going to send out after today is there's some really good resources that Jane, you spoke about, spoke to me about, and Laura's also spoke to me about the NDSS. Can't remember what it's called now.
That's quite a good booklet. The pregnancy and type 1 diabetes, or something along those lines.
Something along those lines, yeah. So what we'll do is we'll send them out to people that have attended today as well. And there's, Laura, I think you mentioned there's quite a few podcasts and things.
So there's a few podcasts around specifically, Mama Beaties, that talk about being pregnant and type 1. And then I've shared a few with Mel that she'll send out that I also found quite helpful, that were more birth stories in general. And then a few of those episodes within that, I think it's called Australian Birth Stories, a few episodes within that touch on women who had type 1 and their stories about giving birth. So they're quite good as well.
Yes, I will email everyone out the list of resources. It'll probably be early next week, so keep an eye out. Sorry, Jane.
One thing I was going to say is when I had my children, it was very fashionable to have a birth plan. And I'm going to suggest your best plan is not to have a plan.
In terms of insulin plan, your diabetes management plan.
Yeah, apart from your diabetes management plan. Yeah, exactly. So I think you do need to have your diabetes management plan, but you can't go, well, I'm definitely going to have a per vaginal delivery. It was safer not to do that and get baby out, and don't be disappointed if that happens. So don't set yourself up with expectations that you cannot necessarily achieve.
I think it's the danger across the board, isn't it, with anybody pregnant? You know, I think that me as well. It's sort of, if you set yourself up and you make these really hard and fast decisions about, I don't want an epidural, I don't want this, I don't want that. You don't want to then have any extra stress on the day of then feeling disappointed or have anything else like that.
So that's what I mean. Don't have a plan. Definitely have your diabetes plan.
Yeah. But, don't lock yourself into all of these ideas, because I think sometimes that can you know, be much more difficult afterwards if things have not gone to plan. I think it doesn't help the way we cope and we then process the whole process that is childbirth. We've got a message from Janine. Hi, Janine. Oh, and it's just gone off my screen. Hi, Janine.
Hello.
Janine used to work with the JDRF. That's why I'm saying hello like that. Would you typically go higher or lower during labour? How different is this in C-section, natural and induction?
So the answer to that question is you could go either way. Okay, so that's you just got to keep an eye on the glucose level. So we know that stress impacts people in different ways. Okay, so some people the stress response will be that the glucose will shoot up. In other people, that stress response, the glucose will drop. And even in the same individual, it can be different. So one delivery, you might find that your glucose levels are high, and another delivery, you find your glucose levels are low. You just keep an eye on your glucose and respond to what's happening. Yeah.
And have that other person knowing what to do with those bits as well. I think that's, I mean, I think, Laura, we've been discussing that just generally lately, haven't we? I think, you know, I was saying that my son was sick the other day and, you know, he's 18 now, and it's like, oh, all of a sudden there's other people that actually need to know it because I'm not actually there all the time now. And it's like, oh, we need some extra little cheat sheets and little bits of information that are handy for people that, you know, are around but don't have those little quirky bits that people that are there all the time, or you yourself know what you need to do in those instances. I think, you know, that's setting up to succeed and having these things in place, because the last thing we want ever is for diabetes to get in the way of living our lives as well and as possibly as we can. So, you know, I think if we set up to have those things in place, then it's got much less chance of getting in the way, I guess.
And one good tip on that I will give is that I've been taking my husband round 2, so pregnancy round 2, to my diabetes educator appointments. So they can run over some things with him. So that's a tip. Take your birth partner to your diabetes educator appointments.
That's a very good tip.
Yeah,
That's a great tip.
Someone was just saying that you call it your what do you say, birth preferences or wish list rather than plan.
Yes.
Yeah, I like that. Yeah,
because there are things you want to do. You know, I remember you can take music and you want things to make it comfortable for yourself. So it's not about not setting it up to how you would like it to be, but it's just that black and white thinking is going to get us unstuck in lots of situations in all of our lives, unfortunately. But if we can go with the flow a bit, then it's much nicer in the end.
Can I just say, when you're pregnant and you're on a pump, it's especially important that you've got some way of testing for ketones. So if you have a problem with your infusion set, you'll go into diabetic ketoacidosis much faster during pregnancy, and we want to avoid that. So make sure you've got some way of testing for ketones, and that you're always carrying a backup form of rapid acting insulin.
Yeah, I think it's one of those things we don't think about all the time is ketone stuff. Sorry, Jane?
Sorry, Laura, did you have any side issues during your pregnancy?
Yes. And one tip, which I think it was my educator that gave to me, was, so I usually with my pump sites will use my stomach and I'll rotate around my stomach. But I was having side issues, so I just completely moved to my back, well, lower back and buttocks. So completely different area to what I'm comfortable or would like to use because of the issues. And it made to be honest, it made big changes to my blood sugar levels. So that was quite interesting because I was going quite high. And as you said, Jane, I didn't have ketone strips and have had to get them recently. So it's definitely a good tip.
I mean, the thing is with ketone strips, they're not cheap. They're cheaper than they used to be. And, you know, it's few and far between, hopefully, when we're having to use them. And then when we do need them, then we often can need quite a few. So it is handy just to, again, have those things around, especially when we're planning these things.
And look, so if budget's tight, get urine keto sticks. So, you know, that's better than
nothing, isn't it? Yeah. So what have we? So we've done pre-pregnancy. We've covered labour, breastfeeding. Anything else? Any other tips, Laura, or anybody else? Anyone else that has any pregnancy tips. And you guys are the experts when it comes to type 1. I much prefer to hear from all of you in terms of the bits that work well and things that you've tried, or any podcasts or any information or anything that you've all heard. Then I would love you to share it with everybody. But
I mean, my one tip is, and we've spoken about it tonight anyway, is to really advocate for yourself. So do a lot of research, lots and lots of research. I listen to a lot of podcasts, and there's also a great Facebook page. I think it's called Type 1 Diabetes Bump Baby and Beyond. That's a really great resource as well. And I think we'll share that later.
It's in the email list, in the list I will send to everyone. Yeah.
Lovely. But yeah, do lots of research and chat to your team, and stay in constant contact with your team would be my top tips.
And be kind to yourself. You know, like, I think nobody's going to be perfect. None of this is going to be perfect. If it's a surprise pregnancy, it's a surprise pregnancy. If it's, you know, if your HbA1c is not where you want, where, you know, they want it to be, then, you know, it's not. And we can't do much about that in that moment. But what we can do is then plan from then on to try and control the bits we can control. We spend so much time worrying about things that we can't actually control. If we can just sort of manage those bits that we have some say over, then you're doing the best possible thing for yourself and your baby. So, but be kind to yourself. I think we're too hard on ourselves as mums, and that just gets probably worse once we have our kids anyway. But, you know, I think that would be one of my tips, is be nice to yourselves and just...
And don't panic if you have a one-off high glucose. It's what it is over time. And, you know, there will be times when you will have a high glucose. You just don't want it to stay high for an extended period of time.
Yeah.
I was going to add to that. Yeah. In my experience, I found that stressing about that one high number was just causing much more problems.
Blow-on effect. Yeah.
Yeah. And so once I realized that I've got to stop stressing about that one number and try and focus on, you know, your time in range and the broader picture of it, definitely helps as well.
So I guess in terms of, we're thinking of things about how to reduce your stress is what I was thinking, you know, like how to reduce your stress and how to manage that anxiety. Because I was thinking, Laura, when you were saying read stuff, sometimes my brain goes to like Dr. Google, and I'm like, oh my gosh, don't read the scary stuff, because I think sometimes, you know, we just can stress ourselves out reading some of the scary things. You know, just, I guess, I don't know, what sort of things have you found useful? What sort of things do you find useful in terms of reducing your stress and anxiety? I always think, to me, a walk's a good thing. To go outside and have a bit of a walk is always handy. Anything in particular?
Sorry, I've got a crying baby in the background. If you can hear it, I have to step away.
She's not behaving.
That's building stress.
So I'll give my quick tips, and then I better run into her. Definitely going for a walk, avoiding Google, because Google does not help at all. And the big thing that I found was handing over some control to other people. So in the sense that if I was struggling with the diabetes management, I would immediately just contact my team and try and not make decisions myself. If things needed to be adjusted, I just went straight to them. And then, handing over other little things that if you can to your partner, to get them to help with things. So I guess in the labour, that's a tip that I would take.
That's great, Laura. Yeah, I think that's great, because that we're not very good at doing that. As I'm going to generalise and say women, sometimes we're not very good at handing things over like that. But I think you've got enough going on making a baby to have to hold everything as well.
I'm going to run with my baby. Sorry.
Make sure Ivy's all right.
We thank you for joining us, Laura. We've got a question here from Ash. Is it more common to have a C-section than natural with T1D, and is one recommended over the other? If there is the option?
Okay. If I think statistics will show that women with type 1 diabetes probably are more likely to have a C-section than women without type 1 diabetes. But hopefully it's not because the obstetrician plays golf on Wednesday. It's because they just think it's going to be a safer option. Still, the vast majority of women will deliver vaginally. when they've got type 1 diabetes. So it's not a given that you'll need a C-section, but it should be because they just want to be extra careful.
Great. Okay, well, I think that's all the questions we have tonight. So thank you so much, Jane, for joining us. That was amazing. And of course, Melanie.
That's great. I've learned so much, and not hopefully facing pregnancy anytime soon with my. So thank you, Jane. I think you just be kind to yourself, go with the flow. You're doing the best that you can, and
exactly.
reach out, I guess, would be the other question. And the other thing to say is reach out if you need any help, any advice, any tips, then we can point you in the right direction at JDRF as well. But thank you, Jane. That was great.
That's my pleasure.
All right. Good night, everyone.
All right. Bye, everyone.